Hi, my name is Chris. I'm from the Royal Melbourne Hospital in Victoria, Australia. Today's paper that I will be presenting is titled Nerve-Sparing Radical Prostatectomy in High-Risk Prostate Cancer Patients is Feasible with Good Functional Results without impairing oncological outcomes. This is a longitudinal, long-term, single-center study. I have no affiliations to disclose at this time. High-risk prostate cancer is associated with a higher incidence of extraprostatic disease. This concept has led to an aversion of nerve-sparing procedures to prevent positive surgical margins as they may increase risk of cancer recurrence. Due to concerns of anticipated inferior oncological and functional outcomes, nerve-sparing radical prostatectomy has not commonly been offered to men with high-risk prostate cancer. Several studies have addressed the impact of nerve sparing on urinary continence and erectile function recovery. A systematic review and meta-analysis recently published reports nerve sparing to be associated with better functional outcomes, while some authors failed to report such associations. However, comparison of functional results in high-risk prostate cancer patients is difficult as data on urinary continence and erectile function recovery after radical prostatectomy in these patients remains scarce. Little is known about outcomes stratified by degree of nerve sparing. Whether nerve-sparing radical prostatectomy should be attempted in these patients is controversial and remains a matter of debate. The aim of this study is to assess outcomes in high-risk prostate cancer patients following radical prostatectomy. In this prospective single-center cohort study, urinary continence and erectile function rates, along with oncological outcomes of 554 consecutive patients undergoing open radical prostatectomy for high-risk prostate cancer from 1996 to 2017 were evaluated. High risk was defined as preoperative PSA greater than 20, Gleason score greater than 8, a PT3 and/or a PN1. Tumor staging. Multivariable logistic regression analyses were performed to evaluate whether grade of nerve sparing was a predictor of urinary continence, erectile function recovery, and oncological outcomes following radical prostatectomy. The validated ICIQ and IIEF15 questionnaires were given to patients preoperatively and at 3, 6, and 12 and 24 months. Urinary continence was defined as complete dryness or occasional loss of no more than a few drops of urine and requiring no more than one safety pad per 24 hours. All patients were continent prior to surgery. Erectile function rates was defined as the ability to achieve an erection sufficient for penetration and maintenance of intercourse. Penile rehabilitation with a PDE5 inhibitor 3 times a week was recommended for all preoperatively potent patients. The study was conducted in accordance with the STROBE criteria. The median follow-up of patients was greater than 8 years. At 3, 6, 12, and 24 months, the nerve-sparing groups had higher proportions of continent patients than that of the non-nerve-sparing group. Multivariate analysis of any nerve sparing was predictive of higher urinary continence compared to patients with no nerve sparing at all time points. Furthermore, overall urinary continence rates of any study population at 3, 6, 12, and 24 months are comparable with the urinary continence rates of patients with low and intermediate risk prostate cancer at all time points who underwent radical prostatectomy during the same time period. Of all patients, 86% had erections sufficient for penetration preoperatively. Erectile function rates at 3, 6, 12, and 24 months were higher in the nerve-sparing groups compared to the non-nerve-sparing groups. Multivariate analysis, any nerve sparing is a better predictor of erectile function at all time points. At 2 years postoperatively, of 175 men who reported erectile recovery, 36% did not require an erectile aid, 30% required a PDE5 inhibitor, 35% required either alprostadil by use of Muse or auto-injection therapy. Likewise, patients with bilateral and unilateral nerve sparing were less in need of Muse or any injection therapy compared with no nerve sparing. Overall, erectile function rates of our study population at 3, 6, 12, and 24 months are comparable with erectile function rates of patients with low and intermediate risk prostate cancer at all time points who underwent radical prostatectomy. After a median follow-up of 7 years, 13% of patients had local recurrence, 5% died from prostate cancer, and 9% died from any cause. Nerve sparing was significantly associated with higher urinary continence and erectile function rates after radical prostatectomy compared to non-nerve sparing radical prostatectomy, with an ongoing improvement in all three groups during the first 2 years after radical prostatectomy. In terms of degree of nerve sparing, its effect on erectile function rates is more pronounced than on urinary continence at all time points, meaning that a wider tumor resection in more advanced tumor staging predominantly affects erectile function rates. In conclusion, attempted nerve sparing in patients with high-risk prostate cancer is associated with favorable urinary continence and erectile function recovery rates after radical prostatectomy and should therefore be offered in well-selected patients.